Hello, and thank you for inviting me to participate in this program. And I'd like to talk to you about voiding dysfunction and neurogenic bladder in children. And I'm Craig Peters, professor and vice chair of urology at the University of Texas Southwestern and chief of pediatric urology at Children's Medical Center in Dallas. When we speak about voiding dysfunction, the clinical presentation can be one or several, including urinary incontinence, urinary tract infection, dysuria or painful urination, as well as hydronephrosis and renal impairment, which of course is the most significant potential consequence. When describing incontinence, it is important to categorize it appropriately, as this can reflect etiology and management. And total incontinence is essentially always being wet, and almost always this is an anatomic or neurogenic cause. Stress incontinence only occurs with vigorous activities such as coughing or laughing, and is actually quite uncommon in children, much more common in adults. Overflow incontinence is small amounts intermittently and reflects inadequate bladder emptying, either due to obstruction or poor bladder contractions, and can also be associated with infections. Urge incontinence is wetting associated with the urge to void that is felt by the patient, but they cannot suppress that void as they should. And giggle incontinence, which is quite uncommon, only occurs with vigorous laughter and probably has a central nervous system etiology, although that's not well defined. When we look at etiologies of incontinence and voiding dysfunction, we always want to consider anatomic abnormalities, which we won't discuss in depth because this is mostly a urological issue, but it is important to be able to recognize these if they should be present, and these can include ectopic ureter or epispadias, among others. The most common cause is probably behavioral voiding dysfunction, which we will talk about at length. There's also bladder instability of various etiologies where the bladder just wants to contract more than it should, and the patient cannot suppress that. And then most importantly is neurogenic bladder dysfunction, again from several causes. Probably the most common is myelomeningocele or spina bifida, which we see in children quite a lot, but it can include sacrococcygeal tumor resection, spinal cord injuries, and occasionally different versions of central neurogenic dysfunction. The structural causes that we should never miss if they are present include epispadias, which is rare, but is well recognized once you know what to look for. And in girls, this is seen with a flattened pubis, a bifid clitoris, a gaping urethral meatus, and is, again, quite rare, even more rare than male epispadias, where you see a splayed or open glans and dorsal penis all the way to the bladder neck, and it is always on the upper side of the penis and not the underside. An ectopic ureter can produce incontinence that often is missed because it is not obvious, but it is constant wetting of generally small volumes, and it only occurs in girls, and family will describe that they are really never dry and do not have any substantial dry interval over a few moments. It can be associated with hydronephrosis or an abdominal mass, but is not always so. It can be associated with purulent drainage from the perineum due to the ectopic ureter. On imaging, we will often see the mass if there is obstruction, and it can show a duplicated system with dilation of the upper part. An IVP, a CT scan, or MRI can be obtained if wetting alone and the ultrasound appears normal, given a strong history. These can always be cured surgically. But we'll focus on dysfunctional voiding, which is really essentially non-neurogenic abnormalities in voiding. And we would term this bladder and bowel dysfunction, or BBD, due to behavioral or developmental factors. There is no identifiable anatomic or neurological cause evident, despite sometimes very thorough workup. It usually develops after toilet training, but can be seen in different versions beforehand. Very frequently it is associated with UTI and sometimes with reflux or vesicoureteral reflux, and the management should be based on the etiology and associated factors. It is quite significant. We know that UTI affects between 2.5% to 3.4% of children, and it's the cause of 1.1 million office visits in the USA alone per year in children under 18. And at least 50%, if not more, of these UTIs are associated with or due to dysfunctional voiding. So this needs to be tended to. The etiology is probably an interaction between behavioral and biological processes as well as maturation, and it should not be considered as purely one or the other, as that can misguide treatment. Once established, however, the patterns can be self-perpetuating. We can basically break it into these categories. The child who is a holder, who is just too busy to go, or it hurts to go, so they try to resist it. Another group is the unstable bladder, or the so-called urge syndrome, which may be at some degree of bladder immaturity, and they always have the urge to go even though the bladder is not really full. And then with toilet training, this is resisted as the child is simply trying to stay dry. So they're trying to retain urine even though they need to empty. The term lazy bladder is not a very good one, but it reflects inadequate bladder emptying and overflow wetting and infections, but often may be a secondary effect or decompensation of prior holding behavior that stretches the bladder too much. Graphically, we can look at it in this way with normal voiding, where there is filling at low pressure and the sphincter is active, retaining urine. And then with balanced voiding, as the bladder contracts, the sphincter has to relax to allow complete emptying. In abnormal situations where there are bladder contractions during play, the voiding is inhibited by voluntary habitual sphincter contraction. The problem is then that when the child decides to void, the bladder squeezes, but by reflex the external sphincter is contracting, limiting the ability to empty smoothly and completely and at low pressure. As a result, there is often incomplete emptying due to this habitual sphincter contraction during voiding, and that's what leads to trouble. Sometimes we can see this very graphically during a urinary flow rate, where the flow is intermittent, or what we call staccato. And on imaging, one can see this spinning top deformity during voiding, indicating non-relaxation of the external sphincter when it should be open to allow urine to flow freely. And this is a good clinical indicator of the severity of the voiding dysfunction. The diagnosis is really based on the history, and it is very typical both in age and pattern. There are some variations between boys and girls, but the remainder of the evaluation is really confirmatory and can be very educational for the parent and child. And it's important to rule out any dangerous causes of wetting and infection that might need more aggressive therapy. When we're evaluating this and talking to the family, we want to ask about the wetting pattern. Is it frequent? Is it infrequent? How much? When does it occur? What's their history of toilet training? Was this difficult or was it normal? Is their developmental history normal? Did they have normal acquisition of basic motor skills such as walking and talking and fine motor control? Importantly, is there any history of constipation? And this has to be elicited very carefully, because families will often think that their pattern of behavior, even if it is reflecting constipation, is normal for them. And there sometimes can be a clear history of bladder dysfunction in the family, although it's unclear if this is truly genetic or just a reflection of family habits. Constipation and wetting are frequently associated and almost always needs to be addressed simultaneously. It is probably due to pelvic floor tightness, the lack of relaxation, and the same tendency to postpone voiding for bowel movements as well as urination. And it likely contributes to bladder instability, which then simply further pushes the child to try to hold, as they don't want to have an accident. It also serves as a reservoir for uropathogens and ultimate urinary tract infections. And in eliciting the history, one must ask specific questions about timing, frequency, and character of the bowel movements, rather than simply asking, is your child constipated? There are probably two approaches to management depending upon the underlying pattern. For the child who is a holder, with voiding postponement, infrequent voiding, there's often with constipation and abdominal pain, and there may be a post-void residual left over detected on ultrasound, and for this we focus on behavioral retraining, which becomes integral, and we'll talk about that in a moment. In children who have the unstable bladder or urge syndrome, there is this sense of always needing to go. They feel they have to go frequently, but it's small volumes, and they may have varying amounts of wetness. This may reflect neuromuscular immaturity. We really don't know for sure, but we need to treat it in a similar manner. The bladder may be relatively small in its functional capacity, and it empties. These kids need a combination of behavioral therapy and bladder relaxants or anticholinergics so that it reduces this urge to void, which also reduces their tendency to retain urine as they're simply trying to be dry. For bladder retraining, I've developed this program I call the 3 R's, which works fairly well, but it does require persistence and dedication of the family to address it. And this would be simply setting up a regular schedule of timed voiding every 2.5 to 3 hours for the child. Sometimes, if available, an alarm wristwatch can be useful in older children, although it frequently becomes something they're not interested in after an initial period of trying it. The second element is to learn how to relax, and this is very important. And this is simply asking the child to double void with a period of distraction between the voids for 2, 3, or 4 minutes, just to slow them down and hopefully get them to take more time to void and be more complete in their emptying. This allows them to empty better, reduce the risk of infection, and reduce the urge to void in a shorter time. And then keep a record of this, whether it's a calendar or a notebook kept by the child or the parent, to record progress, and it also serves as a reinforcing tool that the child is making some progress. Otherwise, they can simply become frustrated and become confrontational. Now, it's important in dealing with these children to recognize the differences between neurogenic voiding dysfunction and non-neurogenic dysfunction. The neurogenic dysfunction is potentially dangerous, and we don't want to ignore it. And the signs that with this it may be present is suggested by the progressive nature of it. So rather than slowly being present, it actually progresses and becomes worse. Can be associated with bowel incontinence, and this can be significant bowel incontinence rather than just minor bits of soiling that we often see with children without neurogenic causes. Now keep in mind that constipation can exist in both situations, so that should not lead you down the wrong path. These children are never really dry and never had evidence of a dry interval. Very importantly, one should look for associated physical anomalies reflecting lower sacral nerve abnormalities, including abnormalities of the foot and gait and walking, as well as the appearance of the lower back. Some of these children will have a history of perinatal complications or anoxia or a difficult birth that may reflect some of their neurological development. Probably the most common and very obvious cause of neurogenic bladder dysfunction is myelomeningocele or spina bifida. It requires immediate assessment and spinal management by the neurosurgeons. Usually this is closed within the first few days of life to prevent infection and further damage. Very often it may require early bladder emptying with intermittent catheterization to facilitate bladder emptying and prevent infection. And there will usually be a period of spinal shock after the closure, and this can last 3 to 6 months. And one should anticipate this and be prepared for it. And it also suggests that urodynamics is rarely useful until afterwards. So studying the bladder dynamics needs to wait a little bit after the time of the surgical closure. Although this is available only in limited parts of the world, fetal closure has some value, but it's limited in availability, and the effect on bladder function is still being sorted out. Now, the occult neurogenic bladder is the one that is potentially the most damaging because it is not recognized until it's late. And these can occur with a variety of abnormalities of the lower spine that can have visible signs on careful examination. And this can include a lipomeningocele, where there may be a mass and an asymmetrical gluteal cleft. It can also include dermal vascular malformations or hairy tufts in the lower spine, indicating an abnormality of lower spine development and potential tethered spinal cord. Often one will see abnormal feet, either very high arches or flat feet, and abnormal toes, sometimes with very pronounced abnormality of the shape of the toes due to lower sacral abnormalities. But one must also never miss a sacral agenesis case where the gluteal fold is very short and the lower spine and gluteal cleft is flattened. And these kids can have normal lower extremity function, but very abnormal bladder and bowel function. this should never be missed and is easy to see on a quick examination during checkups of almost every child. There are associated conditions in neurogenic bladder dysfunction that one needs to be aware of, and these include various pelvic conditions such as anorectal malformations, cloacal exstrophy, or a history of pelvic surgery, especially that of a sacrococcygeal tumor or rhabdomyosarcoma tumor, as well as Hirschsprung's disease surgery. Spinal cord injury, of course, is well associated with neurogenic bladder dysfunction. There are also several and varying degrees of bladder dysfunction with central nervous system abnormalities such as cerebral palsy, encephalitis, and some of the neurodegenerative diseases. These are somewhat variable in their manifestation and require individualized care. Transverse myelitis or Guillain-Barré syndrome often produces bladder dysfunction and often requires management, although sometimes these cases will show significant improvement in bladder function. It's very important to keep in mind what the goals of management are for bladder dysfunction from a neurological cause. Really, the most important thing is preservation of renal function. Kidney function should never be put at risk for the sake of continence. Nonetheless, that often can happen, as the thing that people see is wetting, and that's what they want fixed. Social continence is important. We cannot disregard it. And it has to be done, however, with the kidneys in mind all the time. Social continence should be with a reasonable time interval for emptying. It should be probably in the range of every 3 hours. If someone has to catheterize every 2 hours to stay dry, that's probably not really social continence. We also want to keep the child free from infection, and we know that kidney infections, pyelonephritis, can be a very serious and life-threatening problem, as well as causing recurrent damage to the kidneys that is irreversible. In neurogenic bladder dysfunction, there are two major patterns that we want to look at and that are addressed in our management, and they are storage and emptying. Inadequate storage can be due to either poor compliance or bladder overactivity, and these are treated differently than the child with inadequate storage due to inadequate bladder outlet resistance. The sphincter does not control urine. It's always leaking, so the bladder really cannot hold much at all. And these obviously are treated very differently. Emptying, of course, is the other key function of the bladder and extremely important. And when inadequate, it is due either to inadequate bladder outlet relaxation or detrusor sphincter dyssynergy, which produces, in essence, an obstruction of the bladder. And this is probably the most important pattern to recognize and to be able to manage, as this provides and causes the most frequent amount of damage to both bladder and kidneys. Inadequate emptying can also be the result of impaired bladder contractility, which can be neurogenic, as along with other causes, and this requires mechanical intervention to provide for further emptying, and we'll talk about that in a minute. So the patterns that we see can be reflected, shown here, where there is outlet resistance and very tight and high-pressure bladder contraction, as well as poor compliance during storage, or inadequate outlet resistance, allowing no real development of bladder capacity, and so the patient really cannot store at all because it's constantly leaking. And then with detrusor sphincter dyssynergy, again, the most important entity to recognize what is causing this is incomplete or inadequate relaxation of the external sphincter, and therefore emptying is at higher pressures and generally inadequate, and this can obviously provide problems with, or produce problems with storage as well. And then with impaired contractility, even though the sphincter can relax, there is not enough pressure to push the urine out, and so the bladder does not fully empty. The risks of neurogenic bladder dysfunction really rest in the upper tracts. And the most important problem is poor compliance, where there's high storage pressures, which produce the risk of obstructive hydronephrosis, as well as reflux, which can, of course, be aggravated by infection. Similarly, inadequate emptying can produce high bladder pressures and risk of infection, although usually not as high a risk as with poor compliance. And high outlet resistance, can produce both inadequate emptying, which puts pressure on the kidneys and bladder, and that can lead to poor compliance, and infection, which is the most dangerous complication, and that's when we start seeing issues with significant reflux and renal scarring due to infection and pressure. And these risks, again, reflect poor compliance and that there's high storage pressure during bladder filling, and this produces the risk of obstructive hydronephrosis and reflux. And we see this as a diagram here showing inadequate outlet relaxation, high pressures, and poor compliance, putting pressure on the upper tracts. So managing the child with a neurogenic bladder, particularly the one with spina bifida or due to myelomeningocele, the key elements are to maintain low storage pressures, and this can be done with anticholinergic medications such as oxybutynin, and there are a variety of other agents, but this works fine in most cases. And in children, because it's a liquid, it's easy to adjust the dose as needed to patient size and response. Botox injections, botulinum toxin, can be used, and some people do feel this is useful, but it does need to be repeated. It's somewhat unpredictable as to how effective it is in terms of reducing bladder pressures, and the duration of its effect is very difficult to predict, so it has to be redosed. The problem is that if these children don't have a lot of clinical symptoms, you don't know that the pressures are increasing until it's already happened. And ultimately, the most complex but still effective approach to keep storage pressures low is bladder augmentation with a piece of intestine. At the same time, we have to ensure adequate regular emptying, and this will almost always need to be intermittent catheterization, and most children with spina bifida will eventually need this to both attain a safe bladder dynamic as well as be socially continent. Some like to start this early in infancy, which is my preference, but you can wait until it's needed and the family may be ready. Sometimes instituting it and starting intermittent catheterization in the older child is a little more difficult than if it's been present for all their lives. Nighttime catheter drainage can help maintain bladder compliance and emptying by giving the bladder a rest for 6 to 8 hours, although sometimes logistically this is difficult to do. Urethral dilation in infants can sometimes be useful, but its long-term consequences may be unpredictable in terms of continence ultimately, and it is not really commonly used today, but it can be a useful temporary intervention early in life. And of course, temporary urinary diversion is an option, such as a vesicostomy, but we'll talk about that in a little bit, and one has to factor that into the long-term plan for the child. Clean intermittent catheterization really became a lifesaver for all patients with neurogenic bladder dysfunction beginning in the early 1970s, and is really a key tool in the management of all patients with neurogenic bladder. And the goal is to provide regular and complete bladder emptying to prevent high pressures and reduce infection and to ensure emptying. It does not need to be sterile. A lot of people thought this was going to cause infections, and generally, if it's done properly and thoroughly, it is not going to increase the risk of infection. You will occasionally have positive urine cultures, and they're to be expected, but usually these are not clinically important and represent colonization of the urine and not real infection. It must, however, be regular. 4 to 6 times per day is sort of our usual. Once a day is not useful, as that just simply allows for contamination without subsequent good emptying on a regular basis. And I have found that many motivated children can learn this themselves and gain independence remarkably. There is a controversy about the value of early intervention for neurogenic bladder in spina bifida, and this is sort of my preference. The rationale is that early intervention with clean intermittent catheterization and antimuscarinics or anticholinergics improve urodynamic patterns, keep the bladder very compliant, and allow good storage, and ensures emptying. There is evidence that it decreases the rate of UTI, of reflux, and upper urinary tract deterioration, and ultimately decreases the incidence of end-stage renal disease. This is still somewhat argued, and some people prefer to wait until evidence of deterioration has shown itself. What we have seen is that the determinants of risk for renal dysfunction in spina bifida include the following, and this is the detrusor sphincter dyssynergy, the inadequate external sphincter relaxation, and therefore poor emptying, high pressures, poor compliance, and upper tract damage. High detrusor pressures, generally due to detrusor sphincter dyssynergy. Detrusor overactivity, also secondary to outlet resistance. The presence of febrile UTI, which is often associated with vesicoureteral reflux. All of these entities should be actively managed to minimize the risk for renal functional decline. And to my mind, in the present day, with adequate resources, end-stage renal failure in a child with neurogenic bladder dysfunction is a failure of therapy, and we should see it progressively less and less over time. Clinical monitoring for the child with neurogenic bladder is important, and there are a variety of regimens. I think in a very basic way, following the renal ultrasound to detect developing hydronephrosis, which would indicate increasing bladder pressures due to poor compliance or inadequate emptying. The development of UTIs also suggests poor emptying or upper tract risk due to reflux, especially if these are febrile infections. And changes in continence can suggest increasing bladder pressures, reduced compliance, inadequate emptying, reflecting overflow incontinence, or changes in outlet resistance, which can occur over time. Now, there is the option of temporary urinary diversion for neurogenic bladder. 30 or 40 years ago, this was the standard treatment, but now it is used less and less commonly, but may be essential for some patients. And this type of diversion can include either a vesicostomy, where the bladder is simply brought up to the skin to allow for free drainage. It's very simple and easily reversed. An ileal loop, where the ureters are attached to a small segment of the intestine that's isolated from the GI tract and brought to the skin. This is what was done for several decades up until the 1970s and 80s, and it's called a Bricker diversion, well known, can be effective, but also over time we realized that it had a significant risk of upper tract complications. There is a in-between option called an ileal chimney or an ileovesicostomy, which in some cases is appropriate, where a small segment of the bowel is separated from the intestine and used to go between the bladder and the skin, particularly in an older child where a vesicostomy wouldn't work. And this can provide for adequate drainage. It can be reversed if necessary. In general, I think the considerations you want to have in mind when this is being discussed is that diversion should be seen as temporary in most children. Most ultimately can be managed with a catheterization regimen with or without a stoma. It also must be tailored to the child's individual situation. In some children and families, intermittent catheterization is just not able to be done for a variety of reasons. So a diversion may be the safest thing to do, but try to avoid, as we would say, burning any bridges that allow you to maintain the ability to reverse this so that the child ultimately could be able to be dry with catheterization and without wearing a bag. All of these can allow for possible reversal in the future. And some of that reconstruction can be much more complex, including bladder augmentation and catheterizable stomas. And this is appropriate if bladder pressures remain high or storage is inadequate. Augmenting the bladder with a piece of intestine is often the best course. And this is well established. It's been done for decades, but it's not simple. We have to be absolutely certain that the child can be catheterized and will be catheterized reliably. And we have to realize there are risks to augmentation, including infection, stones, bladder rupture, and metabolic abnormalities, particularly in those who already have some degree of renal insufficiency. If there is very poor outlet resistance and the child is therefore wet, we have to be very careful about making that bladder neck tighter if you do not also make the bladder larger with augmentation, as there is a high risk of kidney damage, as making the bladder neck tighter can change the dynamic of the bladder in terms of its storage, and that can put pressure on the kidneys. We have to be sure that the child or his or her caregiver will be able to empty the bladder regularly. So some of the key points in children with myelomeningocele and neuropathic bladder of various etiologies is that early intervention to maintain bladder compliance and good emptying is usually the best strategy in my perspective and over time. Keep bladder pressures low and make sure the bladder gets emptied. If you can achieve that, you can both protect the bladder, protect the kidneys, and protect the child. This condition can change with time. Continued monitoring is essential, and this can be due to neurological changes, spinal cord tethering, and growth. Increasing hydronephrosis, development of UTIs, and increased wetting are all signs that the bladder is changing. You cannot ignore these in these children. Finally, I'd like to briefly touch on urodynamics, since this is often used in the setting of neurogenic bladder dysfunction as well as non-neurogenic bladder dysfunction. If urodynamics is being considered, and you have to keep in mind it does not always give you a clear, simple answer. We want to ask, what is it we need to learn? What can we learn from urodynamics? What are we going to do with the information? And will this actually help your patient? So if we think about urodynamics in children, what do we need to learn? Well, reflect on what this bladder is supposed to do. And we've talked about this. It's supposed to provide for storage with capacity and continence, and it protects the upper tracts from high pressures. The bladder has to provide continence. There has to be outlet resistance, reduced or normal storage pressures, and we have to think about the detrusor and sphincter coordination. How well do they work together? And we have to think about bladder emptying. Does the bladder contract? Does it do so at a low pressure to protect the upper tracts? And does it do it in coordination with the sphincter? And therefore, we have to think about what can affect storage, what might be affecting urinary continence, and what determines effective emptying. And one of the simplest measures from urodynamics that is important is bladder compliance. And it reflects the ability of the bladder to store urine at a low pressure. Now, a normal bladder capacity can be roughly calculated in a child by measuring the age in years plus 2 times 30 milliliters, and this will give you the volume in milliliters roughly. There are other formulas, but this one tends to work the best. And then bladder compliance is an important concept and very simple once you understand the direction of it, and it is the change in volume of the bladder and the change in pressure with that change in volume. So if we have an example here where the volume is 50 and increases to 300 milliliters, and the pressure goes from 5 centimeters of water to 14 centimeters of water, that would be a compliance of 28 milliliters per centimeter of water. That is good compliance. In another example, however, if the bladder goes from 50 to 300 milliliters, and the pressure goes from 5 centimeters up to 48 centimeters, which is what we might see in a child with a neurogenic bladder, that compliance is only 5.8 milliliters per centimeter. And that is very poor compliance, suggests increased wall tension. Ultimately, this is going to damage the bladder and further damage the kidneys. And this is what a urodynamic tracing might look like, where we have abdominal pressure and subtract that from the bladder pressure. That gives us the so-called detrusor pressure, which is what we really care about. And in this tracing, not only do we see a rapidly increasing pressure as the bladder is filling, but we also see multiple contractions, and these are uninhibited contractions reflecting a combination of both poor compliance and overactivity. And that's the kind of information that we can gain from urodynamics, and in some of our case examples, we will touch on those. So I hope this was helpful in giving you a brief overview, definitely more simplistic than it needs to be, but it should give you a good perspective on how we think about bladder dysfunction, both neurogenic and non-neurogenic in children, and some basic strategies to approach it. And hopefully we'll have time for questions and review some cases. Thank you very much.